Hello, this is Dr. Carrizales. My research topic is an exploration of contemporary issues on apical root resorption following en masse retraction of anterior teeth during orthodontic treatment, and my PI is Dr. Cheever. The introduction, previous studies have found the cause of root resorption following orthodontic treatment to be multifactorial, with biological factors, treatment mechanics, and patient presentation as the main players. Mild root resorption happens in the majority of orthodontic cases, while severe root resorption has been reported to affect from 3.23 to 14.8 of orthodontic patients. Maxillary incisors have the greatest risk of severe root resorption. Guidelines to categorize the severity of root resorption have been devised, such as Malgram's, which assigns scores from 0 to 4, with 0 representing no root resorption and 4 being severe resorption greater than a third of the initial root length. This review paper considers contemporary topics in root resorption in anterior teeth, focusing on en masse retraction mechanics, in order to provide a clear view of the most current research. For the methods, first I searched PubMed and the Roseman database on November 18, 2025, with the following terms: orthodontics, the mesh, root resorption mesh, and en masse retraction, and limited the search to the last 5 years. 84 results were obtained and screened. After the exclusion of systematic reviews, book chapters, results in a language other than English, and treatment done with clear aligners, 13 articles were assessed for eligibility and 7 were disqualified. Devised then a literature matrix with the 6 articles accepted, and then I created a heat map chart based on the amount of root resorption found per article. There were some color-coded visuals that followed Malmgren's classification: green for no resorption, yellow for mild, orange for moderate, red for severe, and purple for extreme. For the results, across the 6 studies reviewed, root resorption was consistently measured. When using CBCT, reported root resorption ranged from 0.7 to 1.8 millimeters. When using 2D panoramic imaging, the root resorption was lower, less than 1 millimeter. Only one article using 3D imaging yielded mild root resorption results, yet they were slightly higher than those found with the 2D imaging. Overall, these studies confirm that root resorption occurs in maxillary anterior teeth during en masse retraction. When following the Malmgren classification, it is found that resorption is mild to moderate with en masse mechanics. Such mechanics included controlled tipping and bodily moving the anterior maxillary incisors. However, there was no statistically significant difference in the amount of resorption with either movement. Adjunctive interventions, such as low-intensity electrical stimulation and micro-osteoperforations, did not significantly increase root resorption. Interseptal bone reduction did result in an increased resorption findings. As mentioned before, this table is color-coded to reflect the amount of root resorption found in each of these studies, with the orange being moderate root resorption and the yellow is mild root resorption. Conclusions: maxillary and mandibular anterior teeth show mild to moderate root resorption when performing en masse retraction. Adjunctive interventions may safely be used without increasing root resorption, except in the case of interseptal bone reduction. One of the limitations of this study, however, is that as 2D radiographs require a greater loss of hard tissue before the changes are evident radiographically, the observed mild root resorption result may not really be comparable to 3D imaging findings. Future directions. Future studies could draw a comparison of adjunctive intervention effects when performed with en masse retraction versus sliding mechanics. Additionally, more research on mandibular anterior root resorption following en masse retraction would benefit the orthodontic field. Thank you and have a great day.